All right, well, I will introduce
Awesome.
Ben. Ben is a good friend of mine. His name is the Blood Types, which makes it easier to remember. He is the medical director for Shark Week for the Discovery Channel, and also he's been on Kings of Pain, which is not very medically related, but you see two morons getting stung by painful items, scorpions and whatnot. Catch it on the History Channel because they don't do history anymore. He's also an EMS director in most of Florida. Does quite a bit of wilderness medicine. As you see, he's a fellow of the Academy of Wilderness Medicine as well. I don't know why he doesn't have FACEIP up there. I guess he's not caring anymore. But yeah, Ben Abo, everybody.
Yeah, thanks, buddy. Appreciate it. Yeah, so here in Florida, and of course, talk about safety third. I just spent all day here training various law enforcement officers how to handle venomous reptiles and deal with snakes. But we're going to talk about drowning care update. You can go. Oh, I'm clicking the next slide. So as Justin said, I do deal with Shark Week, and I love it, and film for Nat Geo Wild and different stuff. Go ahead, Chris. And that was actually filming for Shark Week. I had to get a couple of those pictures in because it was just so beautiful. Go ahead. I thought I hid that one. Good old selfie. That's what I look like. So I have nothing to disclose. I did write a couple of chapters in the Wilderness EMS textbook that Chris talked about. We get nothing from it. And I just love getting the passion out. If you want to take a quick look, that was the QR code with the notes. But the big things that we want to get down to is we're going to review some water emergencies, take a deeper look and dispel a lot of common myths and strengthen your knowledge base. Because there's a lot of things and misnomers about it. So that's the take-home notes. Gonna quick take a look at that QR code. And I'll send that out afterwards. Big things to take home. Know the terms. Reverse the hypoxia. Think about the brain. A lot of people think about lungs for drowning, but think about the brain. If there's no obvious major mechanism of injury, don't worry about spinal restrictions. And remember that denial is not just a river in Egypt. You have to understand that these people absolutely can come back and you can make a difference. We have a lot of paradise here in Florida. This is on the Miami-Dade fireboat, our old one, downtown Miami, where we have plenty of water. I live most of my time in Naples, and we just have water everywhere. We have our usual medical calls. This is in Miami Beach. You know, our general medical cardiac arrest that we're running, and we have all the resources that we need to. We get a fire truck, we get an ambulance, sometimes we get a physician, we have multiple paramedics, we have all the drugs and different things, and we work our resuscitations. Pre-hospital care, we are all about successful resuscitations and getting things out to whatever we need. But not everywhere do we have everything that we need. Good. We have a lot of tools that we've gotten through EMS. Some things make sense still and some don't. But when you get to this beautiful area, and this is my view, I used to kayak to work. The hospital's up to the right, and this was my morning commute. With the sun starting to come up, was pretty nice. But obviously, there's a lot of risks there because we have so much water and so many kids and adults. Go ahead. So a lot of this is based on one of my best friends, Andrew Schmidt, who's a drowning expert, started Lifeguards Without Borders. And we do a lot of preaching. We're both Florida physicians. And I mean, we've been talking about drowning care. This is from 1237 BC. And if you look at these hieroglyphics, you see two guardsmen turning the pharaoh over and just banging him on the back, trying to get the water to come out. And you know what? Drowning still exists, right? We all know about it. Go ahead to the next slide. If you look at a little bit more modern but still ancient Chinese medicine, I thought one of the things would be to make a fire. So imagine you get called to a drowning. It's like, okay, let's make a fire and let's get smoke and hope that we can get the toxins out of them and get the evil out of them. Or let's find a rock, push them over it, and try and get the water out of their body. Or let's find the nearest ox and have them jump around. And these motions to get the water out of the lungs, we haven't gone very different. I usually have video that shows that this stuff's still exist, but I have some screenshots to show you. We haven't gone that much further. Sailors a lot would turn, you don't want to waste the rum, but you'd put them over the barrels and roll back and forth to try and get the water out of them because they knew that the water was what was causing the damage. This is a tobacco enema. This is literally where the phrase, which is probably Dr. Hensley's favorite phrase, blow hot smoke up someone's rear end, comes from. But they actually believed that the tobacco enema would help get rid of toxins, and this was part of drowning resuscitation not so long ago. Getting into the 50s and 60s, there are different methods that people would treat with drownings. And again, these are all outdated methods that don't really make much sense to us. Honestly, things just continue to go over the years. So nowadays, we've got helicopters, we've got boats, we have gamma pressure chambers that are portable, we have CPR, we've got machines that do CPR for us, we've got ECMO, paramedics, physicians, we have all these drugs. But is that really making a difference when it comes to drowning and the statistics? And that's a big question. We have all these things, but I need to take care of the basic stuff, or this is all useless. So if you go to the next slide, globally, this is a gross underestimate. They estimate about 388,000 deaths. There are a lot of places where they don't even have records. We don't know what villagers drown and stuff. And this is not even including mass casualties, does not include suicides or homicides, does not include natural disasters. That is a lot of people dying. In the United States, we have about 4,000 deaths per year, and it's probably a little bit more because sometimes we'll say something like heart attack on the death certificate or COVID, but really it was drowning. And then here where I live in Florida, there's about 400 deaths a year, and a majority of these are kids, and we can really make a difference. And you have plenty of beaches and all, but if you look throughout the literature, there's all these terms that go out: drowning, near drowning, wet drowning, dry drowning, secondary drowning. All these terms really muddle the waters. No pun. All right, pun intended. Let's be real. We go to the next. In 2005 or 2002 was a meeting, but in 2005 there was a research paper that came out looking at all the textbooks and the medical literature, and back then, looking at 60 years of drowning literature, there were 33 different definitions of drowning. So how can you really grow as a field in resuscitation for drowning when you're not all talking about the same thing? So if you go to the next slide, I want to ask you, this is one of the articles that a couple of us wrote, and all the stop using the bad terms. Go ahead. So I want to ask you all, what is drowning? If you go to the next slide, when you have drowning, there are three things. Drowning is the process of respiratory impairment due to submersion or immersion in any liquid. You only have three choices, right? It's drowning or submersion. You have three choices. You either die, or you're injured, which is seen, there's signs and symptoms, but they're reversible, or you have no injury at all, they're completely fine. That's it. Drowning, respiratory impairment from a liquid, you have these three choices. There's no dry drowning, near drowning, secondary drowning, or anything like that. The terms that I really want to make sure you avoid, because it ruins the research, the education, the understandings. No near drowning, no wet drowning. No dry drowning is like foodless choking, right? It's not a near drowning even if they drown near the wall. It doesn't make much sense because the older terms were like, well, if they die within 24 hours, then it's a near drowning. Can you imagine telling a mother, hey, I think your kid drowned, but we have another 8 hours, we'll let you know if it was a drowning or not. Doesn't really make much sense. And you have people all the time, they're like, well, is it salt water or wet water or fresh water? Is it it just confuses things when the resuscitation is honestly all the same. I was very proud. One of my off-duty captains saved his neighbor, the godson. But the headline said here, who nearly drowned, right? And they kept talking about near drowning, near drowning. No, this kid drowned. Now he was saved, but this is filed under, look what it says under filed under, near drowning. It makes me nuts. So if you click, you can see that I don't want that. Absolutely no. So it's a drowning. You'll see me, Seth Hawkins, Andrew Schmidt, a bunch of us always trying to fix the media because people literally were coming into the emergency department demanding CAT scans, CT scans for their kids that were coughing because they were swimming a day earlier. Ridiculous. So what always happens is you have submersion, whether it's on purpose or accidental too long. They struggle, you have some sort of breath holding, which is natural, and you gasp. That is the natural chain of events of what's going to happen. You have an airway obstruction when you gasp. That could be across a closed glottis, or maybe water's filling the airway. Either one, it doesn't matter. It's an airway obstruction and it causes hypoxia. And that's the underlying pathophysiological reason for what's going on. The hypoxia, the lack of oxygen, is the primary cause of any injury, any death associated with drowning. So we need to reverse that. And that's the main goal, not all the drugs and different stuff. And I want you to change your thinking. Stop focusing on the lungs, which is an important aspect, but the overarching goal is the brain, right? I'm really sick of dealing with stroke and all these meetings I have to go to as an EMS physician, but drowning is absolutely a brain injury, and people can be fixed, dilated, hypothermic, but still be brought back. So a lot of my education, and this lecture is the same whether it's the hospital or pre-hospital, it's very EMS based because pre-hospital, we are the ones that will make a difference whether it's a successful resuscitation or not. And that's where we all come into play. So whether it's oxygen, through a mask, through a pocket mask, the ventilations, that is an underemphasized treatment of what we really need. Does anyone want to take a guess what I'm referring to here with 21's greater than 0? Yeah.
Room air better than water.
Exactly. Or even no ventilations. I see a lot of hospitalists, physicians, paramedics that they want to give ventilations, but they're either told, oh, just do CPR hands only, and you're not doing any oxygenation or ventilation, which are two different things, or they're not doing any ventilations until they hook it up to the oxygen bottle. Get those rescue breaths in. I'd rather have 21% oxygen or a little less because that's what we're exhaling is better than 0. So as soon as you can, stop the drowning process and give those ventilations. So that's where 21 is greater than 0. Now, this is a screenshot from a video because I didn't trust the Wi-Fi and all, but there's a couple things to notice here. One, there's foam coming out of her mouth. That happens when salt water mixes with surfactant in your lungs. You can absolutely ventilate through that. Number two, these people are obviously not ventilating. They're doing a horrific CPR, but her eyes are, it's hard to tell in the picture, but her eyes are actually open and she's trying to gasp for air. But they're just pouncing on her chest and not helping her to breathe. In fact, they're lifting her head up like this and closing off her airway, but this is exactly what you don't want to do. Here's a child that's being held upside down in Thailand. You can see the foam coming out of his mouth, and they're just shaking him upside down, trying to get the water out. This is ongoing resuscitation. This, even in a developing country, is a picture on a phone. So is this much different than the hieroglyphics that I showed you from 1237 BC? No. Sorry. Now, if you see that surfactant or the foam, you can, a lot of what of us would want to do is you want to oxygenate, or you're trying to oxygenate, you suction, so you give oxygen, then you get more foam. So you suction again, and therefore you're not giving oxygen. absolutely what you need to do. If you just see that foam, if it's pure water or vomit, yes, suction that out. But if it's the foam, just ventilate right through it. I guarantee it's going to be okay. Now, someone like this is not a selfie, but someone like this that's in cardiac arrest on the beach, it's pretty obvious what their cause of death is, right? It's probably going to be cardiac. So the oxygenation is not a problem. So if you click the next slide, um, the tank is full. Their oxygen tank in their lungs are full. They can be ventilated, but their pump is broken. So absolutely, compressions take priority. If you go to the next one, which is drowning, the tank is empty. There's no oxygen getting to the brain, and it's a respiratory cause. So absolutely, the ventilations take priority. Big difference from hands-only CPR to full ALS care. Now, a lot of us went to hands-only CPR and BLS, and compressions take priority over everything. However, even in the 2010 guidelines, they still said specifically CPR for drowning victims is still an ABC approach. So again, cardiac arrest, cardiac in nature, VFib, VTAC, compressions, and shocking takes priority. Drownings are usually an asystole bradycardia PEA. You absolutely want to, if you need to fill the tanks, they need oxygen and ventilations. Now, if you actually look at the research, spinal immobilization, the prevalence of a C-spine injury is absolutely low at drowning, even if they're in waves. If there's no clear signs of trauma, like they were witnessed to jump into shallow water, or they have trauma over their head, they got hit by props, don't delay resuscitation. Worrying about C-spine, you need to ventilate them. Absolutely. Definitely, I don't think it's on any of your protocols, but that's Dr. Heimlich in the background. Um, do not do abdominal thrusts to try to get water out. These will delay ventilations, and we all agree. AHA, ILCOR, USLA, ERC, delay P, we all agree not to delay ventilations. Click again there. So we've done our resuscitations, right? And it's all about oxygenation and ventilation, airway management, suction only if you need to. Worry about preventing accidental hypothermia. But what about the other ones? What about the injuries where they're drowning, but they're submersion, but not cardiac arrest? This is Dr. Spielman. He's in Brazil. He looked at this huge case load, right? Especially you want to see drowning, you go volunteer in Carnival in Brazil. They looked at 42,000 drownings, and a majority of them were released at scene. And how many of them actually died or had ongoing injuries? So if you look at the next, this helps you determine, do they need to be flown? What's their treatment? Can they just be educated? If you assess them, they had maybe a cough, no foam, clear lungs, you just release them and say, hey, if you get short of breath later, then go to the hospital or call 911 or 119 or 999, whatever you want. If they had a little bit of foam or airway in their airways, or they had a slightly abnormal lung sound, then the mortality went up a little bit. These are the people that need to go to the hospital, and they need oxygen, high flow mask or whatever else. And we'll get into some of those specifics. Large foam in the airways, again, but a normal blood pressure, they still did well. Their mortality jumped up a bit from 0.6 to 5.2, but still the treatment is oxygen and hospital. When you get into the hypotension, respiratory arrest, or cardiac arrest, that's really where you need IV fluids, positive pressure ventilations, and maybe even CPR. So those obviously, so the people that had any foam in the airways or abnormal lung sounds, they need to be transported. They need oxygen, maybe more, and they need to go to the hospital for ongoing care and evaluation. Go ahead. And go ahead one more. I'll send you that comic. I do love it. So what are the things that we need to prioritize? What are our treatments? Air and breathing, You absolutely have to establish and prioritize ventilation and optimize oxygenation, right? And oxygenation and ventilation are two different things. Go to the next. So how do we do that? First, you can start with non-invasive. So you put them on a non-rebreather mask. As long as they can maintain a patent airway, they're maintaining well, absolutely give them oxygen. You can do it with nasal cannula, but I prefer non-rebreather because you really want to get as much oxygen as possible, and they're probably going to need it for several hours at least. Go ahead. If non-invasive PPE or like CPAP, things like that, if they're maintaining their airway and they're not vomiting, great. This can be very beneficial to help get air and oxygenation in. But research has really shown if you don't have rapid improvement in their ventilation, oxygenation in a couple minutes, I'm talking 5 minutes, no difference, they need to be intubated and properly taken care of. The next level up would be, of course, endotracheal intubation. So if they're not able to protect their airway, large amount of foam, large amount of emesis, CPAP is not working, you endotracheal intubation, which of course with that then would lead into the next slide, which is our mechanical ventilation. There's with what settings to use, there's no drowning specific trials, large scale or anything like that. You usually kind of rely on the same things and follow ARSNet type protocols for ventilation. Accidental hypothermia. You absolutely do not want this. Submersion, they can get very cold. It's absolutely common in drowning, even in a hot environment, and it leads to worse prognosis. So you need to keep them warm. You don't want them too hot, but you absolutely need to stop accidental hypothermia and actively warm them during that initial resuscitation. I remember it was the day before my birthday when I first moved to this part of Florida. We had a prolonged drowning. There's a 5-year-old trapped in a car, and they were able to get him out. 45 minutes, he was underwater. He was absolutely cold. They were doing the resuscitation, and I'm like, we need to warm him, warm him. The other doc is looking at the pupils like he's gonna call, and I said, you're not calling this. We warmed the kid up with chest tubes, active rewarming. We resuscitated him. The kid walked out of the hospital a week later. So don't let the accidental hypothermia take part. Go ahead. Radiography, once they get to the hospital, x-rays do not correlate with outcome. They don't correlate with disposition. They don't correlate with an ABG. If they're going to develop ARDS, often, sure, they have an abnormal chest x-ray early. Do I get one? Yeah, I don't prioritize it. If they refuse it, I don't push it. I usually just get one after they're intubated if we're at that point. Head CT, normal CT, no prognostic value whatsoever. So if they have an abnormal one already, all right, it's probably gonna be a worse outcome, but I'm not in a rush. And I see a lot of people dummy down their resuscitation to get a head CT when it's not gonna change what's going on. Their pupils can be fixed and dilated, but they still have good recovery from a drowning. As we said with the C-spine injuries, it's very rare. Now, if they're intoxicated or obvious facial trauma or cuts above the head, great. But actual C-spine precautions might hinder your resuscitation. So don't let it get in the way if they're not breathing or ventilating. Go ahead. Lab testing. Horrible. There's no clinical value. It's not going to do anything for us. You were not seeing major electrolyte abnormalities, and they don't mimic, even when you do have them, they don't mimic real pathology. So it's not a priority whatsoever to help guide you. Capnography, a little bit for the ongoing resuscitation, fine. But otherwise, laboratory testing doesn't do much for you. Antibiotics. Absolutely no evidence to support empiric treatment. And just because they have fluid on the lungs with an initial chest x-ray has no correlation that they're going to develop pneumonia. So you should tailor treatment to if they develop a fever or you have bronchoalveolar samples from bonking them. Otherwise, no empiric antibiotics. Steroids, not shown to have any benefit or harm. Diuretics, same thing, no evidence for harm. Sorry for the noise behind me. So no steroids, no diuretics. Now ECMO, there's only a little bit of specific evidence with drowning specific, but there's no evidence of harm, and it actually has been recommended as a potential treatment if you get to that point. There are some good single case studies, but larger studies, we're not against it, but we're not necessarily for it yet. Go ahead. Therapeutic hypothermia, same thing. We don't really do it, but you want to prevent accidental hypothermia and just prevent the too much heat, like any medical cardiac arrest. So disposition, what's going to happen once you get them to the hospital? So there's very little literature specifically other than Spielman stuff, which was refusals and all. It's mostly pediatric and young adult, but we did get a lot of interesting information out of the statistics. Go ahead. So if they have a normal lung exam, or they have normal mentation, normal respirations, they've normalized vital signs, even if they're initially off, but now they're better on room air, I'm going to observe them on room air for 48 hours in the ER and then reassess and potentially send them home. From that point, if you go to the next slide. After those 48 hours, if they remain okay, cool, they're going to go home. They're going down the right pathway. If they decompensate at any point, okay, now I'm going to admit them to either ICU or to the floor and give them their ongoing care. And it's like a nice, easy disposition from there. Now, automatically, if they have abnormal lung exams, they have altered mental status and respiratory distress that it has improved, or they have any hypos, hypoxemia, hypotension, hypothermia, even if it's improved, I'm going to admit them to the floor, give them oxygen so they get care for at least overnight, 24-hour stay. Go ahead. The prognosis is very interesting. Now, a lot of people are like, well, they're drowning, they're old, they're not going to make it, or they can. Looking at all the studies, a lot of people are worried about, is it salt water or fresh water? Is it warm or cold? Here's what really matters. Go ahead to the next slide. There is a very strong association with submersion duration. So how long from when they're stuck underwater, the fluid in their lungs or in their airway, to getting their first ventilation? That is absolutely a strong association. Decent association with EMS response. If we can get there faster to help treat them and ventilate them, great, we get a little bit. But salinity of water has a very, very, very weak association. And honestly, the pathophysiology and the treatment is not changing between salt and fresh water. Now, if you go to the next slide, there's absolutely no association with age outcome, water temperature outcome, and witnessed or unwitnessed. Mind-boggling, because we're always like, well, an unwitnessed arrest, it really doesn't make a difference. It's the submersion, the timing, and the EMS interventions that really make a difference. But we found out of all those studies and a couple of newer ones that there's no association. So I want you to take them. I want you to know those terms. I want you to reverse the hypoxia. And I want you to think about the brain. And to reiterate it, because I feel that certain things need to be repetitive and redundant. If you go to the next slide. I want you to know the terms. I want you to reverse the hypoxia, and I want you to think about the brain. Going to the next there. These are some great resources that I'm going to email out to you. Drowninglit.com is Andrew Schmidt, my buddy, is telling you about. He goes through the newest literature and he puts on the website. We just kind of decode it, which is pretty great. And there's been some other great things for really in-depth talk about drowning and resuscitation for the biggest things. And honestly, with proper oxygenation ventilation, you guys have Bondi Beach there in Australia. If you watch that show, their resuscitation, they're not even EMTs. Their resuscitation practices are beautiful. 2-person BVM. They'll get them, they take care of the ventilations, they stop things. They're not doing half-ass CPR on a surfboard. They're just ventilating, then get them to shore, and then do it. So you really can make a difference. That's what I have for you on drowning. If you want to go to the next slide. That's my contact info. I apologize that we had some technical stuff before and I couldn't play the videos, but I think I just need to come to Australia and visit you and lecture. But does anyone have any questions? I know that some of these things go against maybe set protocols or textbook understanding, but this is definitely the latest science.
You wouldn't like it here. We don't have any sharks.
What's
Yes,
that?
we do, Cliff. Cliff said we don't have any sharks, which is an absolute fabrication.
Yeah.
It is Bondi, not Bondi. The
Sorry,
Gadigal
yeah.
language is not very Anglo-centric.
Yeah. Sorry about that.
Any questions?
And yeah, I'll actually be in Australia filming for Nat Geo. I'll be on the West Coast, around Perth. Not too long. You got plenty of sharks. Any questions about drowning or resuscitation, though?
Nope. Wait, are there questions on the WhatsApp? Let me walk up. Those aren't questions. That's a picture of ScoMo. Oh, so most drownings are pediatric. Is there any advice about the timing of OG or NG tube insertion or the resuscitation of the obtunded or arrested patient?
Great question, and I'm going to put that in. As soon as you take care of someone's airway, I would decompress their neck. If they're being intubated, definitely decompress right away. If they're not actually vomiting, you're not taking their airway with endotracheal intubation, then do not worry about putting an OG tube or an NG tube in. Only just do it as soon as you can if you're intubated.